Thank you so much. I want to thank the Institute of Medicine. I want to thank the panel. I want to thank you all for including me here today. And I realize a couple of things. One is that I'm standing between you and the wrap-up and going home after this horrible snowstorm that you had to endure being here in Washington, D.C. I also have a moment similar to that of Bill Barth in that when I looked at the schedule, Dr. Esther Sternberg, who presented yesterday, here she is, was my mentor when I was 17. And it was just so exciting to realize that we'd actually be talking at the same conference a couple of years later. A couple of years later, just 2 or 3 years later. So I also feel like I'm being called back to present in front of someone who I care very, very much about. I think it's a unique time to give this talk about what are the things we want to think about when we look at studies, when we look at research, as we plan the research for the future for that on birth settings. So I don't think I'm going to give you anything controversial. It's not going to be like the last panel, but hopefully it will give us something for us to think about as we design the future studies and as we try to interpret the literature that we've had and we've talked about for the last day and a half. And I want to remind us that we're coming back to this topic after a presentation after it was first discussed in 1982 when there was a report that came out on research issues in the assessment of birth settings. And some of the issues, some of the considerations that I'm going to talk about today, like so much of what I do, were present in 1982 as well. And I just want us to remember that, and that we do need to try to make as many steps forward, although often we can't make as many steps forward as we'd like. Let's just keep that in mind. The majority of what I tried to focus on was the birth settings and health outcomes state of the science from panel 3 as I looked at the considerations. But in reality, the considerations for research actually cover all of the panels that were discussed. But I'm going to kind of formulate it on these 4 talks that were presented yesterday in panel 3. And just to highlight the first talk, which was on alternative versus conventional settings, one of the major points from that presentation was that alternative settings do impact and in many cases reduce interventions. Now, what are the things that we need to think about? What do we need to consider when we look at the research that went into these findings? One is whether or not the patient delivered in an alternate setting or a conventional setting, how that delivery occurred was in relation to the institutional norms and the institutional policies that they had in that birth setting. And you can't really separate those two very easily. So it's just something to keep in mind as you look at these studies. What goes on in those institutions, what policies they have, will help to drive what outcome you're going to get. In addition, the caregiver staffing and roles, what types of caregivers there are, what's the timing of their giving of care? Do they have a set time frame? Are they allowed to be only on for 8 hours? Or can they stay on for 24, 36 hours? And what are the roles that the different care providers have? Because that will impact your ultimate results. And then finally, the types of patients studied. And this is going to be a recurring theme and is something we can't really get away from completely. The type of patient who is interested in delivering in an alternative setting may be different. And I say may be different than one who wants to deliver in a conventional setting. The second talk was on collaborative group studies from the UK, which one of the major points was that low-risk women have very rare adverse perinatal outcomes, which is a great thing, one of the reasons I went into obstetrics. And that women in their first pregnancy, as for almost anything, have higher risk than women who've had a prior pregnancy successfully before. In addition, the point that came across was that the interventions that occur are more common in hospital settings, right? What do we need to think about when we look at these UK collaborative group studies? Again, that choice of birth setting and the patient bias, again, plays in here. How do you separate that out when you're evaluating these studies? And again, the caregiver and staffing roles. The third talk was on processes of care. And just one major component from that talk was that overall the goal is to try to do fewer interventions, right? Well, where you are located is going to change and help to define what interventions occur. What are the institutional policies? What is required for that birth setting? And that, so you may want fewer interventions, but there may be a policy that all patients have to have X. And if they all have to have X, then they're all going to have that intervention simply by being there, not that they necessarily need it. So to try to do research to look at interventions, you need to also look at the policies of the place where the person is giving birth. Again, the caregiver and staffing roles, the selection bias, and outcomes measured was also something that's really important. I'm going to come back to that in a later slide, because as we look at what happens in the different settings, we have to look at how we evaluate that. Is APGAR score enough, whether it's 10 at home or not? And the last presentation was that of the effect of the built environment. Dr. Sternberg elegantly showed that environment affects what happens to us. We have neuroendocrine immune interactions and physiologic responses to where we are and to what's going on around us. And it impacts our mental and our physical health as well. Much of this data was from non-obstetrical populations. It would be fascinating to look at this in obstetrical populations and to see how this interplay really occurs in the obstetrical group. So if we look across all of these studies and all of the panels that we have had and listened to over the last day and a half, one of the considerations as we go forward in planning research studies and as we evaluate the studies that have been done to date is we need to remember that there is a selection bias in the patients who are being studied. Women planning home births typically have a lower obstetrical risk. They often have later gestational ages. They typically desire less interventions and prefer a specific care model. There's nothing wrong with this. It's just something that we have to have in our mind as we're understanding these studies and as we plan studies. Because if you plan a study and someone wants this, they're not going to accept something else. They will not be randomized to it. It's important when we look at studies and design studies that we think about the study design. Overall, due to the inherent nature of what we're studying, hard to do randomized controlled trials, which has been the hallmark of what I've done for the last decade, really trying to answer the question with a well-designed randomized controlled trial. As we look at these studies, we need to look at what were the inclusion and exclusion criteria, and how was low risk defined in one group, how was normal defined in one group, as compared to in another study. Because sometimes there's slight differences, and that might change what it is that we are trying to evaluate. When was that delivery decision determined? Was it determined at 12 weeks? I'll certainly have patients come into me when I see patients on Wednesdays in clinic and say, you know, yeah, I'm here for my first trimester screening at 13 weeks, and I'm going to deliver at X. And I'm thinking, you have so much to go through between now and then. When is that decision going to be made? And when is it really appropriate for that decision? And my recommendation is always, it's a great idea. Keep thinking about it, because there's so many different things that are going to happen to you in this pregnancy. So the timing of the delivery decision in these trials and in these studies needs to be taken into account. A delivery decision in the first trimester is very different than a delivery decision in the third trimester. And when we look at the studies that compare to cohorts or historical studies, we need to be very careful about the selection bias of the population studied. Not that there's anything wrong with them, but just to understand what got you there and what is that patient group like. What were the outcomes measured, and what were the institutional policies that went into that group? And as I promised, I'd come back to outcomes. Most studies to date report on short-term outcomes. Honestly, in obstetrics up until a couple of years ago, most studies reported on short-term outcomes, right? What you wanted was an APGAR score of 9 and 9, or 9 and 10, I guess. But in reality, what do we really want? We want the kid to be doing well in kindergarten at age 5. We want the socially adjusted adolescent. I now have a 14-year-old. I really want that, right? So whereas what we have in our reporting are APGAR scores, mortality, and hospital discharge, we need long-term information. how does it impact reproductive health, gynecologic health, family and childhood outcomes? That's what we really need. But if this field doesn't have it, don't feel bad, because really, this is the goal for all of obstetrical outcomes, and we have this for very, very few. There are some other considerations that I'd like to bring for us to think about as studies are developed for the future. One is that the topic in general, and appropriately so, includes women at low obstetrical risk. The implications of this for those women who are at higher risk really aren't known, and yet some of those women may wish to have a home birth, right? So how you take this and generalize what you find you have to do very, very carefully, because they are not included in these studies. We also must understand the climate that we are in. The availability of some obstetrical services is limited for certain types of conditions and really drives some patients to make their decisions. The ability to do a vaginal birth after cesarean or a vaginal breech delivery is limited in many areas. Understanding neural immune connections in obstetrical populations is something that I think will be critical for us to move this field forward and to look at the implications of this on our workforce and our settings. So as we look at the whole topic of considerations when evaluating studies on birth settings, I think it's important that evaluation of data must take into account the limitations of the available data that we have, and then use that to build the future. Remember, the patient selection bias, the study design issues, and the outcome studies all play a role and are all important as we design future studies. We must remember that as we design studies, many will want to generalize them. And we're going to have to either be very cognizant that they cannot be generalized, or develop them in some way to allow some degree of generalizability. We need to look at different organizational models of care, the implications on the workforce, and clearly there are many unanswered questions. The good news to me, as I'm thinking about the future work for the National Institute of Child Health and Human Development, is there's many unanswered questions. There's much work to be done. So when we go from 1982 to today, many of the issues are the same. But we have also come up with lots of data to help us formulate these new studies for the future so we can have healthy outcomes. Thank you so much.